provide some more education to the field, and in terms of all of the physicians that are interested in these topics. I'm really delighted to present Dr. Jens Uwe Voigt. I'm gonna be very brief in trying to do a very tight summary of Dr. Voigt's resume, just by mentioning that has been trained in Germany, in the UK, and the USA. He's currently a staff cardiologist and professor with the KU Leuven, Belgium, where he leads the echocardiography laboratory, cardiovascular department, university hospital, and the imaging research group with several international fellows and PhD students. His field of interest is myocardial function imaging, to which he contributed significantly in the past years. The current focus of his work is on clinical application on high frame rate imaging, ventricular disynchrony, and technical aspects of the applied echocardiographic deformation imaging. He has authored or co-authored over 130 papers in peer-reviewed international journals, and has authored and co-authored several echocardiographic textbooks and international recommendation papers. He is a fellow of the European Society of Cardiology, a member and/or nucleus member of the National Belgian and German Imaging and Cardiology Societies, and an honorary member of the British Society of Echocardiography. We are really delighted to have you here. Very honored that you accepted to be with us in this web seminar. And with all of that said, I'll pass the word on to you, Dr. Voigt.
Very, very much for this very kind introduction. Good afternoon. I have to think, because we have 6 hours time difference. I'm calling in from Europe. Good afternoon, ladies and gentlemen. I'm really delighted to be invited to this webinar series of GE HeathCare for cardiology. And the title of today's webinar will be Beyond Systolic Strain, Post-Systolic Strain, Dispersion and Work. As already said, my name is Jens Uwe Voigt. I'm from the Catholic University of Leuven in Belgium. And just to give you a rough idea what we are talking about, if you look at the map of the world, then this little blue dot here, this is Belgium. And roughly in the center of this blue dot is Leuven, which is a tiny little medieval city with one of the biggest and yeah, I think also best universities of Europe. And the yellow marked countries are some of the countries where our current research fellows come from, which work with us in the Medical Imaging Research Center. Actually, I'm calling in from the Baltic Sea coast of Germany, where I'm currently on vacation, but we are used to Zoom conferences nowadays in these very sad Corona times. So I hope I can bring this webinar to you via Zoom in a comparable quality as it would have been during a lecture at the conference. So let me start with the content. We are talking about strain and about the assessment of myocardial function, and we have different ways of doing that. And the classic way was introduced in 1998. This is quite a while ago, 22 years, when the first publication was launched about the use of tissue Doppler based strain assessment of the left ventricle. This is still today a good method to work with, because it's one of the methods with the highest temporal resolution in non-invasive cardiac imaging. However, it's a bit cumbersome to use, and especially if you want to have a comprehensive assessment of the entire left ventricle, it's not so straightforward. We are also limited to the Doppler direction, so we can only assess the deformation of the myocardium in the direction of the ultrasound beam, and therefore it has some limitations. The popular method is certainly the speckle tracking or 2D speckle tracking method. This one was published in 2004, so it's also 16 years old already when the first publication about a commercial software application in cardiac imaging was launched. And this is based on a completely different way. It's an image analysis method which is looking at features inside the image, and those features are then followed over time and used to calculate the deformation of the myocardium. This method is very easy to use because it usually needs only a few clicks with the mouse to have a good and comprehensive assessment of left ventricular function. We get strain curves, we get peak systolic strain, we get curved M modes, and a lot of other things. And one of the most interesting things it brought to us was global longitudinal strain. Global longitudinal strain was a new way of assessing global left ventricular function. It's a deformation of the muscle, and we measure it along the myocardium, so along the midline of the myocardium usually, and what we expect is a shortening of the myocardium of 20–21%, something in that range. Global longitudinal strain has become popular, and we know that it is a very sensitive method. We can measure very subtle changes in myocardial function, and when we think of like chemotherapy patients, we can see global strain changes in a significant way before we see any changes in ejection fraction. So it's very good for to detect very small changes. And the reason for this is probably that it is a very reproducible method. So if we compare for example, the coefficient of variation of different echo parameters, global longitudinal strain is a parameter that has a very low variability. If we compare that to other parameters which we take for granted in daily echocardiography, like the E/A ratio or the posterior wall thickness, you are amazed how high the variation of these measurements is in daily clinical practice. Not so global longitudinal strain. No wonder that this method found its way into the guidelines, and when you look at the new chamber quantification guidelines, which were published by the European Association of Cardiovascular Imaging together with the American colleagues, the American Society of Echo, this was an update of the old guidelines, which were 10 years old at that time. And this time, for the first time, the word strain appears, and strain is actually recommended as a method that can be used for global function assessment. And it's also mentioned as a method that can be used for regional function assessment. And we have a task force from the EACI and the ASE, and this task force tries to find a consensus on what is good for how we should measure left ventricular strain and how we should measure other strains like right ventricular or atrial strain. As I said, it's mainly used for global longitudinal function, and we are talking not so much anymore about regional left ventricular function. So what I want to do in the following minutes is now that I focus a little bit more on the regional function that we can assess with strain measurements. Of course, you are used to that type of parametric imaging already. If you use the GE software, you know these bullseye views, and these bullseye views show you already the segmental peak strain. And you see, for example, like in this patient here where we have an anteroseptal infarct scar, you see that the peak systolic strain is severely reduced. You see this gray area here in the bullseye, but I think you don't really need a bullseye for that. You should probably recognize that also with your naked eye. But there is more to strain assessment than just peak systolic strain. Actually, in most of the cases, peak systolic strain is not the ideal parameter to look at regional function. And I would like to illustrate that here in this example. What you see here is two strain curves from a patient which has an infarct. And The green curve comes from a normal segment. The blue, the red curve comes from a segment with an infarct scar. And when you compare these two curves, then you see that actually the peak strain of both curves is the same. So peak strain would not distinguish a normal from an infarcted segment. So we have to look at something different. What we usually measure is the strain at peak systole. Okay, that's this one. But we have to describe the red curve in a different way. We have to look, for example, at the strain at end systole, and we have to measure the strain after systole, so the post-systolic strain. When you compare these curves, the normal curve starts the descent at the end diastole, and it has the peak at end systole. So you see these yellow lines and green lines here. The yellow line end diastole, that's the R wave usually. The green line is end systole, aortic valve closure. The red curve, completely different. We have a little bit of a stretching even in the beginning of systole, and then we have reduced systolic shortening, so that the end systolic strain is much lower in relative or in absolute terms, because we are talking about negative numbers. And then we have a post-systolic shortening that happens after aortic valve closure. So what you realize from this is that it's very important to look at timing of events. And timing of events means you have to define end diastole and systole. End diastole can be defined by the ECG, for example, with the R wave, as I already said. The ideal way actually of defining it would be the mitral valve closure, because if you have, for example, a left bundle branch plug or so, the QRS complex can be distorted, and then this definition doesn't work so well anymore. The end systole is defined by aortic valve closure, and what happens if you have these definitions wrong is illustrated in this example. On the left side, the good measurement, end systolic strain in the red curve, -9%. If we now have a wrong definition of the aortic valve closure by just 4 frames, then you see that our so-called end systolic measurement moves downwards, and we have now suddenly -15. On the other hand, if your end diastolic definition is wrong, then what happens is that you move your baseline, so you move your 0 reference, and the entire curve is shifted up. So again, you get a wrong measurement of the end systolic strain. So timing is very, very important. And it is particularly important in pathology, because you can imagine in a normal curve, like the green one I showed you before, the end systolic and the end diastolic and the end systolic part of the curve are relatively flat. So moving your definition a little bit back and forth doesn't matter so much. But in pathology, like if you have a post-systolic shortening, or if you have a left bundle branch plug with completely disturbed curves, then it matters a lot. And you can see here the percentage change in your strain values when you move just a few frames backwards or forward. So you get huge errors if you have a bad timing definition. Furthermore, regional function assessment is a challenging task, because we want to go regional. We want to define segments, and we want to know if a segment is good or bad, for example. So what we have for tracking, less data, we have less data. So there's less information to average. The tracking and the regularization algorithms of the software are very important, that they work very well. And also regional image artifacts play a bigger role if we go local. And therefore, the measurements of regional strain are not as reliable as the measurements of global strain. We have tested that in intervendor comparison study a few years ago in Leuven, where we invited different companies to bring their machines and their post-processing software, and we scanned the same patients on all the machines. And you see here the retest variability of the strain measurements, peak strain, end systolic strain, and post-systolic strain. And you see that we have huge differences in the variability in the different vendors. And all these variabilities are much, much higher than what we had as the average variability of global longitudinal strain. What is also important is that the software which you use for speckle tracking strain doesn't smooth too much over the area. If you want to go regional, you really want to detect local changes in myocardial function. So if you have a small scar, your software should show a small strain at that point, but in the neighbor regions, the strain should be high and normal. So what we also tried, we invite our patients had all infarct scars, and all these infarct scars were characterized by MRI delayed enhancement, so we knew exactly where they were. And here you see a comparison of the strain values in the non-scar region and in regions with transmural scar. And you see also here that the different companies have huge differences in their strain values. So some companies have a very high difference between the normal myocardium and the transmural scar myocardium, and some companies have a very small difference. So what we want, actually, if we want to have a certain software, is that we want to have a low test-retest variability. So if we put that on this axis, we want to be somewhere here at the bottom, and we want to have a high range of values. So we want to have a high fidelity to follow regional myocardial function. So in other words, a software which is here in this corner is not so good, and a software which is here in this corner is something better. And if you look now at the field of the candidates, then you can estimate approximately where these companies are with their equipment and their software. So after having said all these bad things about regional strain assessment, you might ask, can we use strain at all for regional function assessment? Yes, of course you can, but you should keep in mind that there are some problems to it, and you should not so much focus on numbers. You should focus more on patterns. So look for specific strain curve patterns when you analyze your data. And I would like to show you a few clinical applications, and I would like to show you a few typical patterns that you can expect in your daily practice. Let's start with an induced ischemia. This here is an old study from 2002. This is done with Doppler strain rate and strain assessment. So you see here a strain rate curve, and here you see the strain curve from a myocardial segment in a patient that undergoes coronary stenting. So during the stenting, a balloon is blown up, so there is no blood supply to the myocardium anymore, and there is a regional ischemia occurring. And what you can see is after 60 seconds of balloon occlusion, this strain curve, which shows a normal pattern at baseline, has a completely disturbed pattern during this acute induced ischemia. And if you analyze that a bit more, then we have to draw the aortic valve closure to get a time reference. And if we look at the strain rate and the strain curve, then we see that we have a cessation of the systolic shortening, and we have a shortening occurring after aortic valve closure. So this is post-systolic shortening, a very typical sign of regional dysfunction. And if you can observe it, that it occurs, then this is usually a sign of an induced ischemia. And this is, for example, something you could try out in a stress echo. So what you would normally expect in stress echoes is that you have a strain rate, peak strain rate that goes up during the stress echo, and you have a systolic strain and systolic and also a maximum strain, which doesn't change too much during the test. It has a little bit of an increase in the beginning, but otherwise it's a plateau. So what to do with that? What we see here, the strain rate would be a good marker to follow during a stress test, but strain rate is something you cannot measure with speckle tracking. Speckle tracking has a too low temporal resolution for strain rate analysis. Although it's offered by the software, you shouldn't use it. The temporal resolution is not good enough. On the other hand, strain can be done by speckle tracking, but strain doesn't show any change. So also that is not a good option. What you should go for pattern analysis, and this is what you would expect. This is an example of a patient during a dobutamine stress echocardiogram, and this is the baseline on the left side in a segment that will later become ischemic and a segment that is normally perfused, and these are the stress images in the same segment. What you can see is that during the stress, the overall strain amplitude doesn't change too much, neither in the normal segment nor in the segment that becomes ischemic. But what you can see is that the pattern of the curve changes. You get this typical sign, what I showed you before. You get this little bit of systolic stretching here, you get a reduced systolic shortening, and you get marked shortening after aortic valve closure, so a post-systolic shortening. And if you see such a pattern occurring during a stress test, then this is a very clear sign of an induced ischemia. This can help you to be more confident in your analysis, although if you're an experienced stress echocardiographist, then you probably will not gain too much from that. Every now and then it will help you to make your decision, but who gains the most are the unexperienced young people. What you can see here on the left side, a novice reader who is more or less tossing a coin when making a report. This novice reader will improve his sensitivity without losing specificity by using this technique. And this is just an example, a clinical example, baseline echo, low stress and peak stress. And you might have doubts, some of you probably may see it clearly where the problem is, but if you're not so sure, then you're just taking your sample volumes, you put it in the region of interest and you put it somewhere else in a remote region as a comparison, and you look at these two regions and you see that this is a completely normal shape with a peak at systole, which is the red line here, so that's absolutely fine. And during peak stress, you see that in the same region you suddenly see a reduction of strain and a post-systolic strain occurring, while the remote region shows still a normal pattern with a peak at end systole. So that's a very easy and straightforward way, and we usually do that with tissue Doppler because it has the good temporal resolution and it's a very fast post-processing. Afterwards, you just put your mouse there and you get the curve, so that's even faster than 2D spectrum. Chronic infarct scar is also something you can identify, and I just would like to show you this little example here from a patient from which we knew that he had a little inferior infarct. We knew that from MRI, and we also knew that the patient had a little bit of troponin. In an echo image, you could have missed this infarct with looking not so carefully. However, when you do strain imaging, or then I was very curious and I tried to do the strain imaging, and when you look at this bullseye, which is completely red, you could become disappointed because it's completely red, which means it's all high end systolic or high systolic strain, so nothing is seen. But what I told you was you should look at patterns. So we have to choose another parameter. Peak systolic strain is not good. Go for post-systolic index, which is something that describes the amount of post-systolic shortening relative to the rest of the deformation. And if we do that, then we suddenly see in one segment a blue region, and this blue region indicates that there is a lot of post-systolic shortening going on. And when we look at our curves, then that's exactly in the two-chamber view, namely at the basal inferior segment, there where we had the infarct and where we have a reduced systolic shortening and a marked post-systolic shortening. So also here we have this pattern of regional dysfunction. Since this is an old infarct scar, it's not newly occurring. We cannot talk about ischemia here. We cannot tell if it is ischemia or an old scar, but it's definitely regional dysfunction. I was also asked to mention mechanical dispersion, and mechanical dispersion is also a pattern analysis of our strain curves. And we focus this time not so much at values, we focus more at the timing, and we compare the peak systolic strain in the timing of the peak systolic strain in the different segments of the ventricle, and we calculate the standard deviation of this peak timing. You know from your clinics and maybe also from studies that patients after an infarct are in danger of getting lethal arrhythmias or sudden cardiac death. We have guidelines that recommend that those patients should get an ICD, especially if the left ventricular ejection fraction is low, below 35%. But when we look at big studies like at this one, almost 1,000 patients, then this ejection fraction threshold of 35% is basically telling nothing. Patients above and below 35% get sudden cardiac death or lethal arrhythmias. So it's not a good parameter to decide if you should implant an ICD or not. If you look at dispersion, you can identify patients in which you can expect an arrhythmia or which are unlikely to develop arrhythmias. This has been shown in a large study with almost 700 patients. And you see here an example of 3 patients, a healthy volunteer on the left side, very narrow, all the peaks are around end systole, so very small standard deviation of 70 milliseconds. An ICD patient without arrhythmias in his record, it was a follow-up of 30 months. This standard deviation is in the range of 59 milliseconds. And on the right side, an ICD patient who had recorded arrhythmias and interventions from the ICD, and this patient has a wide standard deviation of 93 milliseconds. And you can show that in these patients, a dispersion of less than 75 milliseconds has a good prognosis, and patients who have a wider dispersion of their peak strains have a worse prognosis with regard to arrhythmias and sudden cardiac death. The next topic where regional function analysis may be of interest is dysynchrony. So we are talking about patients which are potential receivers of a cardiac resynchronization therapy. And you know the problem there, that despite of our ever-changing guidelines, we do not reach a higher success rate than something in the range of 60–70%. So most patients benefit, but there's always a third of patients that doesn't benefit from the therapy. And it's a costly therapy. It takes some effort. It's not without danger during the implantation. So it would be nice if we could select these patients better. And we also know that these class 1 to A to B recommendations, they do not really predict the response of the patient very well. This is an analysis which we did in our Predict CRT cohort, which we published about a few years ago. And in this analysis, we could see that patients with a class 1 indication showed this typical 30% non-responder rate. But also the 2A and the 2B indications had a lot of non-responders. And what was also frightening is that the patients who had a contraindication for CRT implantation, according to the guidelines, even in those patients, we had responders. So our guidelines are not sensitive enough. We miss patients that might benefit from the therapy, and our guidelines are not specific enough because we implant too many CRTs in patients who do not respond. So how can we improve the situation? We should look at myocardial function, at regional myocardial function, at the synchrony of the myocardium. And the typical pattern you can expect in a left bundle branch block patient is what I show you here. The early activation appears in the septum. So what happens here is an early short contraction of the septum with a very fast inward motion of the myocardium, and this is what we call a septal flash. And then with the delay of the bundle branch block, we get a contraction in the lateral wall, and this lateral wall contraction happens late in systole, and at the same moment the septum is stretched. As a result, you get a rocking motion in the apex, and so you have two typical patterns that you can already appreciate by eye. This is the septal flash, so this inward motion of the septum, and it's the apical rocking, so this laterally directed motion of the apex during systole. And if you see these two things, then this is a good candidate for CRT, these patients are the responders. We have shown that in the Predict CRT study, which is a large retrospective analysis of more than 1,000 patients, where we could show that there is a clear relation between these signs and the volume response, but also between these signs and the survival of the patients. Patients with a typical mechanical dysynchrony, they survive better than those who have no dysynchrony with a hazard ratio of 2.5. So at that point, I would like to use the opportunity to invite you to join an international multi-center trial. It's the AMAND CRT trial, which we have started in Leuven. And we want to show that we can evaluate CRT, or we can improve CRT patient selection based on mechanical synchrony, namely flash and rocking. We want to include 700 patients, and for that we need help from everywhere in the world. We want to start in the next weeks with that, and if you're interested and if you want to join with your center, write me an email and I can tell you more details about the trial, and we can discuss if your center can join or not. So I was talking about visual assessment of mechanical dysynchrony, but we are talking here about strain. So what is strain good for? Yes, you can show exactly these changes in mechanical and regional mechanical function in the strain curves. If you're not trusting your eyes, or if you're not sure what you should say about that, maybe if it moves too fast or whatever reason, just do a strain analysis and you are very clear. What we see here in these patients is in the septum, the early contraction, a shortening of the myocardium. A shortening means that the curve goes downward. And this is what we see. With the onset of QRS, we have a downward slope of the septal curve.
Bueno, mientras esperamos, realmente lo que nos ha dicho acá es lo que nosotros también promocionamos, porque él realmente es nuestro mentor, hemos leído mucho de sus trabajos. Lo importante es que en nuestros laboratorios podamos repetir lo que los papers, los trabajos dicen. O sea, lo único que sirve es lo que uno puede reproducir en sus propios laboratorios. Pero sus mensajes son realmente muy claros, muy claros. La importancia del Doppler tisular, que sigue estando vigente por su alta resolución temporal, el strain global como ya indiscutido y el strain regional como muy importante, pero con algunas limitaciones, fundamentalmente en la determinación del tiempo del cierre de la válvula aórtica, ¿no es cierto? Y vamos a aprovechar y preguntarle cómo él mide el cierre de la válvula aórtica, porque existen tres métodos manuales para medirlo, con 2D, métodos con Doppler para medirlos, o un algoritmo propio que tiene el equipo. Así que hay una pregunta muy interesante de cuál es el método más confiable para medir el cierre de la válvula aórtica, porque vimos que 4 o 5 frames de diferencia en la medición pueden cambiar los valores. Después, bueno, la importancia del strain postsistólico no diferenció muy bien lo que es normal de lo que es anormal, pero él tiene trabajo sobre el tema. Se le puede preguntar qué valores son los normales. Habló de la dispersión. Dio una cifra un poco diferente a la que di yo ayer. Yo hablé de 57 milisegundos, pero eso era en un trabajo del Chagas. Y cada trabajo, por supuesto, tiene su corte, su umbral. Acá para el infarto agudo de miocardio, él dio un umbral de 75, dio un umbral de un poco más alto, en la cual uno debe pensar que el paciente puede, si tiene una fracción de eyección baja, ser un candidato a hacer arritmias malignas, y entonces hay que prever esa situación con un DAI. Y bueno, y esperemos poder tenerlo en contacto nuevamente porque nadie mejor para él preguntar. Ya hay 10 preguntas de los asistentes.
¿Qué le parece? Tal vez podemos llegar a responder algunas de estas preguntas. Si quiere, por ejemplo, una forma confiable de medir el cierre de válvula aórtica, porque por
Bueno,
más que
después se la podemos hacer a
lo
él.
podemos hacer.
Yo le digo cómo la realizo yo y después podrán ver. Yo lo realizo con el Doppler continuo de la válvula aórtica porque veo muy bien los clics y trato de que la frecuencia cardíaca sea similar en las tres vistas y eso lo tomo como base. Por supuesto que es importante tener en cuenta, bueno, que no haya arritmia, que la frecuencia cardíaca no sea variable y que se haga en un momento en que el paciente esté, por supuesto, ya en reposo, tranquilo, si tenemos los valores basales. Yo lo hago con el Doppler continuo a nivel del tracto de salida de la válvula aórtica. Pero bueno, vamos a ver qué dice él. Hay otras
Hay
preguntas.
más preguntas que están en inglés de una persona que aparentemente es de los países nórdicos, entonces preferiría que la responda el doctor Boyd porque esta persona no nos va a poder entender en el español. Entonces,
Parece que sí, es el doctor Vinayak
exacto.
eh, Batganskar que hace la pregunta en inglés. Después se la vamos a hacer a él, porque si yo la
Ah,
contesto en español, él no lo va a entender. Y además no quiero decir que lo que yo diga sea cierto. Acá hay una pregunta así en el cual se considera anormal la deformación poshistólica, ¿no es cierto? Y él tiene claros criterios que yo llamo los criterios de Voigt cuando doy las charlas, que son, se considera anormal cuando parten de una deformación sistólica ya anormal, o sea, con una deformación sistólica normal, la poshistólica tiene menos importancia, pero no es el único criterio. El otro criterio es que sea más del 20% y el otro criterio que tenga una duración mayor de 90 milisegundos, o sea que entre bien en la protodiástole. Él pone tres criterios y un cuarto de un valor absoluto también. Así que le vamos a preguntar a él, pero él define muy bien lo que es normal de lo que es anormal, porque todos sabemos que la contracción o deformación o velocidad poshistólica en la gente joven, en cada uno de nosotros, puede ser absolutamente normal, 10, 15%, en condiciones normales. Y esto es lo que nosotros hemos hecho algún trabajo con el doctor Mora en España y tratamos de demostrar que esto se debe a la contracción tardía de las fibras ascendentes. ¿Mm?
So let me try to continue. Very sorry for that. Let me try to continue with the presentation, and I will try to catch up with the time a little bit. The next application, or the new application I wanted to talk about, is the work analysis. Just I would like to take you back a little bit to your physiology lessons during your studies. And when you think of the pressure volume loops you were presented at that time, you remember these loops showing you the work diagram of the heart. And these were pressure volume loops, so showing the relation between the volume of the left chamber and the pressure inside the chamber. And what was shown there in this loop is the so-called work diagram. And this work diagram describes the stroke work. This is the work that is performed by the heart towards the outside world. So if we want to apply this concept to like a patient with a left bundle branch block, like here in this example, again, we have this septal flash and the apical rocking, and now we give a little bit of dobutamine. And the heart starts to contract more vigorously. That's an inotropic substance. And you see on the right side that you have a heart that contracts clearly more. You see more flash, you see more rocking, but the contraction of the chamber, the ejection fraction, the work that is performed towards the outside world doesn't change at all, because this left bundle branch block is a condition where the walls work against each other. So we have an uncoupling of myocardial function and performed work. So this global work assessment is not a good approach. We have to go local. We have to measure the local function of the myocardium. How can we do that? We measure, we do the same thing. We use this concept of the pressure volume loop, but we try to apply it locally.
Bueno, le decía entonces que por qué suponíamos que había en todos los pacientes una deformación posistólica normal, especialmente en las bases, porque ese es el lugar en el cual uno está evaluando de alguna manera las fibras ascendentes, que son, como ya demostrara bien Torres Waps, las últimas en contraerse. Y se contraen precisamente en el periodo temprano de la protodiástole. Y son también responsables, por supuesto, de la succión. Así que no preocuparse por una deformación posistólica que es corta, que tiene menos del 20%, y que tiene una deformación sistólica regional en ese territorio absolutamente normal, de menos 20. Así que con eso, esos son los criterios de Voigt. Él fue el primero que los ha descrito.
So, we were talking about the segmental stroke work, and that if we look at this diagram, then we have always a counterclockwise rotation of the loop. This is completely different if we have a patient with a left bundle branch block. You remember the strain curves in the early activated segment with the early shortening, and in the late activated segment with the late shortening. So this is the septum and this is the lateral wall. And when we look now at the stress strain diagram, then we see that this loop has not a round shape anymore. It has a shape of 8 in the septum. And this counterclockwise rotation in the basal part is something we could interpret as positive work, but in the upper part it has a clockwise rotation, and this has to be interpreted as negative work. So in this time the septum stretches and the septum wastes work which is performed elsewhere in the ventricle. So you can nicely show how the walls work against each other, because on the lateral side here in this segment you see how big the loop becomes, because the lateral wall has to work more because part of the work is wasted in the septum. And we have tried to correlate these findings in the stress strain loop area with the glucose uptake of the myocardium by scintigraphy as a sign of metabolic activity. And we found that there is a very nice correlation between the stress strain loop area and the glucose uptake. So it really tells us something about the regional work that is performed. And we have also looked in a sheep model, which was paced on the right side to mimic a left bundle branch block conduction pattern. What happens to the hearts if they are exposed to such an abnormal workload in the different regions? And what you see here is the normal conduction. On the left side, you have the normal loops everywhere in all the segments. These are short axis views. And on the right side, you see the same heart under right ventricular stimulation, so having a sort of a left bundle branch block pattern. And in these, under this condition, you see that the loops in the septum change the shape. We get this figure of 8 telling us that work is wasted, and the loops at the lateral side become wider so that we have more work performed on the lateral side. And when we now look Oh, this is now the graphical illustration of all the sheep, and on average. So in the normal conduction, we have more or less an average the same distribution of work in all parts of the wall. On the right, under right ventricular stimulation with the left bundle branch block pattern activation, we see that the work performed in the septum becomes less and the work performed in the lateral wall becomes bigger. And when we now look at the remodeling of the hearts over the course of 8 weeks, then we see a very interesting finding. At baseline, we have the normal wall distribution, so all the parts of the heart are equally thick, while after 8 weeks of this pacing, of this abnormal activation with the left bundle branch block pattern, we see that the septum gets thinner and that the lateral wall gets thicker. So the remodeling of the heart follows the workload that is imposed. So what we get basically is a normal configured ventricle at baseline, and after 8 weeks we have a hypertrophied thick lateral wall because it has to work a lot, and we have a thin hypotrophied septal wall because this septum is unloaded because it contracts very early when there is no load. And this is what we have to recover when we do CRT in our patients. So we have to recover the function of the septum. So does that also work in patients? Can we measure work in patients? Here it's a little bit more complicated because in patients we cannot measure the left ventricular pressure. In patients, we have to sort of assume the pressure, and this is done in a very clever way, which was developed by the group from Oslo. And there they said the pressure curve looks pretty much the same in all patients in each part of the cardiac cycle. So what if we take a standard pressure curve and we just normalize it? We just measure the systolic pressure, so we can scale it, and we also can adjust the time intervals to the time intervals of the patient, and in that way you get a pressure curve which is pretty much the same as the pressure curve in the particular patient. So the error for the estimate of the work in the region of the myocardium is rather little. So that's a nice trick, and in that way you can also do this work analysis in patients. On the other hand, there's another problem because we assume that the pressure equals the wall stress. And this is not always the case because this is connected via the law of Laplace. And when you remember the law of Laplace from your physiology lectures, then the law of Laplace looks at the radius and the wall thickness. So if we have differential wall thickness and if we have differential curvature in different parts of the ventricle, then this relation between chamber pressure and wall stress is not always the same. So, and if we think of a patient with a left bundle branch block with a thick lateral wall and a thin septum, so we have differential wall thickness, and we also have different radii, so the circumferential radius and the longitudinal radius, for example, is different. And we have 3 different strain components, and we consider only 1 strain component. So it's a lot of assumptions that have to be made to apply this work analysis to a patient. But still, it's not too bad. It seems to do something decent. What I show you here is non-invasive strain data from patients. So we just assume the pressure curve, but we still consider wall thickness and curvature. And what you see here is in the left bundle branch block, the figure of 8 in the septum and the big lateral curves. And in the patient before CRT, we see the same as in our sheet. We have this wall, this work distribution, which shows very little work in the septum and very high work in the lateral wall. And after CRT, so a week after the CRT implantation, this has changed completely. And the interesting thing is that this work difference, which is very high in the beginning, is reversed. So we have actually more work performed in the septum than in the lateral wall after CRT. And this is good because we have to challenge our septum because we have to recover the function of the septum, and the septum now suddenly is exposed to the normal loading condition, but the septum is thin, and therefore it has to do more work per volume unit. You shouldn't forget that what we are looking at is work per volume unit, and has to perform more work per volume unit than the lateral wall, which explains this nice inverse difference. So what we do now, we have a relative overload of the septum and a relative unloading of the lateral wall. And this is actually very predictive for CRT response. When we look at this work difference between lateral wall and septum and look at the remodeling later, then we can show that there is a nice correlation between the two. In other words, if we have a high load imbalance and we can homogenize that, then as it is shown here in the upper panel, pre-CRT, post-CRT, then after 1 year we have a nice reverse remodeling of the heart. If we have no such loading imbalance, and if we cannot change that, then after 1 year we have no remodeling. So can we use that in the clinic? Because this was all with extra software and extra calculations. Yes, we can also use that in the clinic. But we have to keep in mind that we are using just the strain and just the left ventricular pressure. We do not consider wall thickness or curvature. And in that sense, it's basically a strain which is weighted by the pressure. In other words, we look at the systolic part of the strain. And when we look at these loops that we can generate with the software, then we also see these typical patterns, but we have to keep in mind that they are not 100% correct. There are a lot of assumptions behind it, but still they work quite nicely. And there are also some attempts already that have been made to find normal values, which you can find in this publication from the Nordic study. We have tested that in a 200-patient study together with the colleagues from Oslo and Rennes and Aalst. And in that study, that was a prospective but observational study, we have looked into the echo pre-CRT and 6 months follow-up. We had scar definition by MRI, and we looked at the echocardiographic work before CRT implantation and the scar extent. And of course, we looked at septal flash and apical rocking. And then we looked into the outcome data of volumetric remodeling and survival of the patient. And we're very happy that this paper was recently accepted by the highest ranking journal that we have, the European Heart Journal. This is an illustration from the work that will come out in the next weeks. So we have a high septal lateral work difference pre-CRT in this example here. This is a patient where we have these typical patterns. We have the figure of 8 in the pressure strain loop, and we have the big loop in the lateral wall, and we have the high work difference. And after 6 months, this is homogenized. The work difference is very little, and the patient is a perfect responder. And when we look at this work difference, then we can see that the work difference before CRT is a good predictor of CRT outcome. You see here the orange line, which is not considering the scar in the septum, and this has a reasonable or good area under the curve of 0.77. When we consider septal scar, which is a contributor or a confounder, an important confounder to the CRT, then we can increase the predictive value to 0.88, and this is a very good value, and this is also something that we get with the visual assessment of septal flash and apical rocking, but of course in a less in a less objective way, because the visual assessment needs quite some training, and that's not so straightforward. With the work, you really have numbers you can work with. So, ladies and gentlemen, despite the few interruptions by the internet problems, I would like to summarize that we have a lot of possibilities to quantify myocardial function by echocardiography, and there's much more than just global longitudinal strain. Regional function assessment should rely on pattern analysis, since regional strain estimates are always noisy. time of events during the cardiac cycle be as relevant information, and you should keep that in mind, that this is important. We have typical patterns such as post-systolic shortening, which are sensitive markers of regional dysfunction. Newly occurring post-systolic shortening can identify ischemia. Peak strain dispersion is something that can predict arrhythmic events. And we have if we have an early septal shortening followed by a systolic stretching during lateral wall contraction, this is something predictive for CRT response. Pressure strain loops are an exciting new tool for the analysis of left ventricular function. They allow to evaluate myocardial contraction in relation to the afterload. This is a method which is new. It has been validated and appears reasonably accurate despite a lot of assumptions that are made. And we can currently say that this is still a research tool, but it might be of interest, for example, in the area of CRT patient selection. So with this, I would like to thank you for your patience with all the internet problems, and thank you for your attention.
Thank you, Professor Voigt. Really very interesting, your lecture, very elegant, with a lot of practical messages. We have many questions. So I will start with the first one. Which is the reliable way of measuring aortic valve closure?
Yes.
Is the first question.
Okay. It depends what you want to do. If you want to do that with speckle tracking strain, then the ideal way is just start with a 3-chamber view, because in the 3-chamber view, you see the aortic valve closing. So you can scroll to the point when the valve closes and you have it. In tissue Doppler, you can have a trick. You take a tissue Doppler line through the mitral valve leaflet, and you see red and blue colors in the tissue Doppler. And when the red changes into blue, you see a little blue stripe at the aortic valve closure. You can use this as an indicator. And the standard way is that you go to a tissue, a Doppler tracing of the aortic valve, and you can measure the closure of the aortic valve relative to the ECG, and this can then be applied to either tissue Doppler strain or speckle tracking strain. This is also possible. So grayscale imaging or Doppler imaging of the valve, these two things, and that should usually do it.
It's another question. In relation to defining the aortic valve closure, what's the acceptable heart rate variation between the clips to be analyzed?
Yeah, so that's difficult to say. We usually accept something in the range of 10%. The software will also tell you if the heart rate variability between the different views is too high. Especially if you work with a Doppler trace, you have to obey that. If you're checking the aortic valve closure directly in the grayscale image, then that's fine, because that's the identical image loop, so you don't need to worry about that. But if you combine different images, let's say something in the 10% range.
Yes, there are a lot of questions. During stress echo, is it a good practice to obtain strain data in early recovery rather than peak stress?
There are two aspects to that. One is the patient is laying there, not moving too much, being very quiet, and you can obtain better data and you have better images for measuring. On the other hand, you may lose information because you have already a decline of the ischemia. So usually, yes, you can do that because there is sort of an ischemic memory to it. You have these ischemic changes also after the end of the stress, but that you should be very quick. So like getting the patient from a treadmill on the stretcher is really on the edge, but it's doable and it's acceptable, yes.
In our own experience with a lot of studies, the time of recovery is very soon. After 2 minutes,
Yeah.
2 minutes, there is a recovery. If you stop the stress echo early when the ischemia starts, no?
Yeah. So you have to be very fast. What we usually do, if we go for ischemia, then we use dobutamine stress echo. And with dobutamine stress echo, you do not have these problems because the patient is laying there very quietly, and you can keep the stress level until you have obtained all the images that you need for your analysis. So in that way, it's probably the safer way of doing it. I would agree.
Another question, is there a cutoff value of post-systolic shortening that could be considered abnormal?
Around in the range of 20–30%.
Can you explain how differentiate normal of abnormal post-systolic shortening?
Which is very much related. You have a little bit of post-systolic shortening in many places of the heart, and this is mainly in the septal region and mainly at the apical part and the basal part of the septum, because the mid part of the septum is relaxing very quickly and early in the after systole. So, and then you have a little bit of shortening in the apical and basal parts of the septum. This is, let's say, in the range of 5% or so. This is very minor, but you can see it in the curves. But this is absolutely normal. If you have post-systolic shortening in the range of 20–30%, and if you have it in combination with a reduced systolic shortening, then this is a pathologic case.
This is a personal question. Do you think that is due to the contraction of the ascending fibers, as was well described by Torrent Wasp?
That's a discussion which is worth another webinar, and I'm not sure if we should enter this discussion now.
Okay.
There has been always the debate if post-systolic shortening is an active or a passive process. Okay. And there are pros and cons for both interpretations, and I'm happy to do another webinar with you about that.
Okay. Another question, is there any strain pattern curve suggestive of fibrosis? Which pattern of fibrosis is usually deciphered from strain data?
Yes. It depends if it is a local fibrosis or if it is a more global thing. We have seen very similar patterns like in an infarct scar, for example, in Fabry disease. If you look at publications from Frank Weidemann, for example, he has shown that in a circulation publication a few years ago in Fabry patients, these patients start with having myocardial fibrosis in the basal part of the posterior wall. And what you see there is exactly the same pattern as in an infarct scar. You see a reduced systolic shortening and you see post-systolic shortening. So this combination can also be found in other types of fibrosis. If you have more a global fibrosis, a diffuse fibrosis, you will just see reduced global strain, but no change in the temporal pattern of the curve.
Okay. You explained that 75 milliseconds was the dispersion time of infarct after myocardial infarct. And yesterday in a webinar I say if we have more than 57 or 60, it is not good in Chagas disease. The cutoff is variable in different diseases of dispersion, of mechanical dispersion.
This might be the case. And I'm also not so sure what we are looking at with this dispersion, because in infarct patients, we are looking at sort of post-systolic shortening and how much post-systolic shortening or how late the post-systolic shortening appears. And in a way, we look at a sort of an infarct size with this number. In Chagas disease, it might be another pathology, or it is another pathology, and it might be another substrate we are looking at. So I could easily imagine that these cutoff values are indeed dependent on the pathology.
Okay.
But in infarct, in post-infarct patients, it's quite amazing that you always come back to these 75 milliseconds, and it's a lot of different studies from different people, different centers, which always end up somewhere in this range of 75.
Yes. Have you time? Because we have a lot of questions.
For me, it's fine. So
yes?
Can
we continue? Another question. Can we consider myocardial works ready for clinical use? If yes, in which scenarios? And finally, do you think it will substitute strain in the future?
As I said in the end, I think at the moment, work analysis is still a research tool. We have to find out how to use it and where are the pathologies where it really has a benefit. The nice thing in myocardial work assessment is that we can consider the loading condition of the myocardium. So all the diseases, all the pathology where loading can interact with the strain values that we measure. And I'm thinking here very much about the right ventricle, for example, which shows very high changes in loading in different pathologies. Maybe the work analysis is a tool that would help us there to better interpret our strain values. I do not think that we need to use it in all cases, so I don't think it will be a replacement for strain. But in certain clinical scenarios where we have high loading changes and where we need to consider these loading changes, I think it is it might have an added value. But at the moment, I would consider it as a research tool.
Yes. How much experience you need to validate the strain tools in different scenarios? What is your recommendation?
I think of my fellows. So when they come to the lab and when they are worked in and they have to analyze their data, there is a certain point when they realize themselves what they did wrong in the first patient. So when we sit together after, let's say, 30 to 50 patients and we go through the data and we discuss it, and then they suddenly realize, oh yes, I see, and I have the feeling I should better measure it again. And that's the moment when they understood what they are doing. And of course, they have to measure it again, but the learning curve is rather steep, so you don't need too many patients for that, but you should have some interaction with somebody who's experienced and with whom you can discuss. And I think the most important thing, what you have to tell new people is, don't believe the curves. It sounds very strange, but you have to analyze very closely what these little dots are doing. When you compare the little tracking dots versus the underlying myocardial motion. And these dots have to follow the myocardium. And if you can confirm that by visual analysis, then you can be pretty sure that your tracking curves are good. But otherwise, you can get into trouble if you just interpret the curve, or if you just interpret even the peak values without thinking about the curve shape and without checking the tracking quality, you can be very much in trouble.
Yeah, Dr. Boyd, according to your experience, what is the pathological value of dispersion in infiltrative cardiomyopathies?
No experience with that.
Okay. Some people use 3 cycles and some 4 to capture the event time. Is there any consensus and explanation?
No, there is no consensus for that. You have to be reasonably accurate with your assessment. So we always capture 4 cycles, not only for the event timing, but also for the grayscale images, because that gives you a little bit of buffer. You should have a little bit of buffer before and after the QRS complex. So it should always be more than 1 cycle. It should be a cycle plus minus 200 milliseconds on both sides. Besides that, I would always recommend to use 3 cycles, because then you have the chance to go to the next cycle or go to the previous cycle and see if that one tracks better. So it just gives you the freedom of a backup cardiac cycle to analyze. And it doesn't cost a lot of memory. Memory is cheap nowadays, so that shouldn't be an issue. And you should talk to your IT department if they think differently about it. I would always recommend 3 cycles of this. And if you have arrhythmic patients, it might be worth even taking more.
Okay, from Peru is another question. The value of the post-systolic shortening in patients with severe aortic stenosis without coronary artery disease. The value of post-systolic shortening in aortic stenosis.
That's a very specific question. I don't know what the value should be there if there is no coronary artery disease. I mean, a severe aortic stenosis should be treated, and after that you can see what happens to the patient. If there is no coronary artery disease, what do you want to do with it? I don't think that it is a relevant thing to contemplate about post-systolic shortening in such a case.
What do you think about the relationship of global longitudinal strain and circumferential strain with normal ejection fraction in cardiotoxicity?
Yeah, this is a very interesting question, actually, because one of the reasons why global strain appears to be so sensitive to us is that ejection fraction is maintained due to the compensation of reduced longitudinal strain by enhanced circumferential strain. So the heart tries to compensate for that, and we get less longitudinal shortening, we get more circumferential shortening. In the end, the ejection fraction is maintained, but since the longitudinal shortening decreases first in most of the cases, we see already change in longitudinal strain, and that makes it such a sensitive marker of early disease. So it's a very interesting question, but the question is what to do with that, because circumferential strain is not so straightforward to measure, and also not so reproducible to measure. So I would probably go for longitudinal strain, because this is the most robust way of looking at myocardial function with strain imaging.
There is another question. Myocardial index in cardio-oncology. Do you see utility in the future?
I think this is outside the scope of today's webinar.
I have a question. What do you think is more important for the efficiency in cardiac mechanics? The base of the heart or the apex of the heart? We discussed this in our lab. Which is more important for the efficiency? The base of or the apex?
I think you have thought about that much more than I. So I think it would be fair if you gave the answer.
No. I think that the apex is more important, but we discuss it, which in a practical view, if it is a disease of the base or is a disease of the apex, which is the contribution of the mechanic in the heart, which is more important, no? That is my questions. The base
Yeah, I think it's difficult to answer, and I don't know if longitudinal strain measurements are enough to answer that question. But probably we need more than that.
No. So I think it's if it's possible to distinguish ischemic disease of non-ischemic disease in left bundle branch block with the soft of mechanical work. If it's possible to,
No. This is one of the issues why it is so important to have additional information on SCAR, because if you look at the loops, a loop of a ischemic septum and a loop of a septum in left bundle branch block, or a septum with SCAR, they can look very similar, and it's very difficult to distinguish both just by looking at the loop patterns. On the other hand, and that has been shown very nicely by the Oslo group, they made animal experiments where they had a left bundle branch block, and then they induced an ischemia in the lateral wall, and suddenly the septal wall becomes a pseudo-normal pattern again back. So there is an interaction between SCAR and left bundle branch block, which is very difficult to distinguish just by looking at strain curves or just by looking at these workers.
Okay, that is all. Our everlasting gratitude for your contribution. So many thanks. And perhaps some people from GE will finish with some words. So I have a pleasure to see you again, and thank you for all your work. Really, you are a leader in these advanced techniques. Thank you for your work and for your words.
Thank you very, very much for the invitation, and again, thank you for your attention.
Okay. Entonces los esperamos a todos a las 5 de la tarde, y a las 7 hora argentina va a haber otros webinars muy interesantes, y realmente hemos disfrutado del Dr. Voigt enormemente. Sepan disculpar alguna interrupción. Se va a editar su presentación, de modo que estos cortes, que nadie tiene la culpa, han ocurrido por internet, no se vean en las presentaciones. Así que les agradecemos muchísimo la presencia y hasta muy pronto.